The following is a presentation on the basics of peroneal tendoscopy, including a review of the relevant surface anatomy, portal placement, and diagnostic evaluation. With the use of a sterile marking pen, the relevant anatomic landmarks are marked out, including the lateral malleolus, superior peroneal retinaculum, and the peroneal tendons. A two-portal technique with a skin bridge of greater than 30 mm is employed. The distal portal, highlighted in blue, is positioned 1 cm distal to the tip of the lateral malleolus. The proximal portal, highlighted in green, is positioned 1 to 2 cm proximal to the tip of the lateral malleolus. The positions of the portals can be changed depending on the location of the pathology. 5 ml of sterile saline is injected into the distal portal. Using a number 15 blade, a 2 mm skin incision is made at the distal portal, followed by blunt dissection with a mosquito clamp to safely open the portal. A blunt trocar is inserted into the distal portal in line with the peroneal tendon sheet. Typically, a popping sensation can be appreciated when the trocar pierces the tendon sheet. The trocar, with the arthroscope in situ, is connected to the water inflow and the pressure is set between 20 to 30 mm of mercury. The endoscope is advanced and the muscular portion of the peroneals can be visualized. The endoscope is then retracted back and now the peroneal tendons can be visualized. Seen here is the peroneus brevis on the left and the retromalleolar groove on the right. The endoscope is maneuvered and the peroneus longus tendon is identified. The peroneus longus tendon is on the left and the peroneus brevis tendon is on the right. The peroneus longus has a round morphology and the peroneus brevis has a flat morphology. The endoscope is utilized to evaluate for the presence of peroneal tenosynovitis, peroneal tendon tears, peroneal stenosis, and a low-lying peroneus brevis muscle belly. Here, evidence of scar tissue and degenerative changes is evident. Next, a small tear of the peroneus brevis is visualized. Gliding of the peroneal tendon is assessed by passively ranging and circumducting the ankle during the procedure. If a therapeutic procedure is required, a second portal is created under direct visualization using a 25 gauge needle based on the pathology's location, ensuring the portal is at least 3 cm proximal to the distal portal to leave a 30 mm skin bridge. Once the portal location is confirmed, a 2 mm skin incision is created using a number 15 blade. A 2 mm shaver is inserted through the proximal portal to debride inflamed synovial tissue, tendon tears, accessory peroneal muscles, and/or low-lying peroneus brevis muscle belly. Extreme caution must be taken during soft tissue resection as adjacent fat containing the sural nerve may be erroneously resected. Attention is directed towards the retromalleolar groove, where a retromalleolar groove deepening is performed to increase the volumetric space to allow efficient gliding of the tendons. This is performed using a 2 mm shaver followed by a 3 mm burr. This procedure can also be performed using a 1.9 mm 0-degree needle endoscope, which is the preference of the senior author. There is almost no difference in the technical steps of performing the procedure when using a 1.9 mm 0-degree needle endoscope compared to using a standard 2.7 or 4.0 mm 30-degree endoscope. This procedure can be performed in both the office setting and in a formal operating suite. Benefits of using a 1.9 mm 0-degree endoscope include the smaller diameter of the endoscope, reducing the trauma to the soft tissue envelope. This in turn will reduce the risk of wound complications. Additionally, it will facilitate more rapid return to work, activity, and sport. There are technical limitations associated with using a 1.9 mm endoscope, as no 1.9 mm 30-degree endoscope is currently available.